Hi, everyone, and welcome back to another hashtag See Arthritis episode. I'm Cheryl Koehn. I am with Arthritis Consumer Experts, and we host this great series. And we're so privileged, honored, and thrilled to be sitting again with Dr. Hani El-Gabalawy. Dr. El-Gabalawy has been a frequent guest of ours over the years. Thank you, Dr. El-Gabalawy, for taking the time to talk to us about the things that are going to be taking place at this year's CRA HPA meeting, but also hear from you about your own work these days. And we're going to ask you to do some crystal ball work for us. We're going to have you peer into the crystal ball and tell us what's going to happen in arthritis. So welcome to the program. I'm just going to tell our audience a little bit about you before we start. So Dr. El-Gabalawy is a professor at the University of Manitoba and has dedicated his research career to understanding the mechanisms initiating and sustaining rheumatoid arthritis, one of the more serious forms of autoimmune type of disease. He has authored the definitive chapter on RA synovial pathology in a top rheumatology textbook. So not only will we call him doctor, we'll call him professor, big professor. Currently, Dr. El-Gabalawy's primary research interests in the autoimmune mechanisms preceding the onset of RA and how they can be modulated to reduce the risk of disease development and progression, something that's of great interest to patients I know who are watching and have that disease. He is particularly interested in the effects of immunomodulatory nutritional supplements in preventing the progression of RA autoimmunity. So hopefully I pronounced all of those big fancy words correctly, Dr. El-Gabalawy. And with that, we'll begin. So welcome again to the program. And please tell our audience a little about yourself and this is how I've been describing it to other guests. What do you do during the day? For our audience who are largely patients.
Great. First of all, always a pleasure, Cheryl. Thank you very, very much for inviting me again to the broadcast. So what do I do? I primarily work with a team. We have funding from the Canadian Institutes of Health Research to undertake some research looking at what you mentioned in your introductory remarks, trying to figure out ways of modulating the risk of rheumatoid arthritis, specifically in First Nations people. And so I spend the majority of my day doing what has to be done for that. Everything from haggling with universities to ethics committees to going to First Nations communities to writing manuscripts to reviewing progress to talking with both lab top benchtop based researchers as well as clinical researchers. So stitching together all the needed components for us to move this research agenda ahead.
I was just going to say, you mentioned the work that you're doing with First Nations, and I'm assuming that's largely, is it on reserve, off reserve?
Both.
Both. Okay.
There's two communities, now three in particular, that we have worked with. One very closely, Norway House Cree Nation, and we've had a relationship with that community for more than 20 years, working up there, going up, taking. It's unfortunately it's a flying community, so we have to transport ourselves and our research team up there. And the logistics can be challenging, especially if you travel during the winter. So we try to do the travel, seasonally, particularly in the summer when there is something called York Boat Days in Norway House, which is the whole community gets together and watches these incredible York boat races on the lake there, and it's amazing the skill and the power that the individuals who kind of steer those York boats. But associated with that, the whole community gets together for health fair on a day. and there's booths set up in the hockey arena, and we set up our booth and try to conduct a study, which is primarily now involved in screening individuals in the community for the risk of rheumatoid arthritis based on having autoantibodies in their blood and not having disease. So, and then we also worked with the St. Teresa Point community, which we haven't worked with since before the pandemic. Although we still, our group here, Dave Robinson and others, still provide kind of outreach clinical services there. And in a third community, we have engaged recently, based on, may I add, an incredibly promising young student from that community, Fisher River, who did a wonderful job introducing us to the community, to the leadership, and allowed us to really establish our research protocol in a study. And then the urban First Nations community, which involves our clinics and other clinics around the city.
You know, so fundamental to one of the health calls to action is to help support and mentor Indigenous peoples into health professions. So it sounds like that's something that's happening in your work. The person that you mentioned who's super promising, I imagine, as a clinician, but also as a researcher.
Yeah, I have to a little kind of a disclaimer here. She is still waiting to find out about entry into medical school. We got her
Okay,
when she was just finishing her undergraduate work. I certainly hope she gets in. I can't imagine that she wouldn't, to be honest with you.
exactly.
I'm not going to say any names because of
Yeah,
confidentiality
of
and all that.
course, of
But
course.
she is incredibly promising, and she represents a whole cohort of pre-medical and medical students in this institution. Our University of Manitoba has focused on recruiting, retaining, training Indigenous students. And I think we've done a particularly good job. And so you're going to see within a very short period of time, a whole cohort of Indigenous physicians, which we hope to retain the best of here, but through a lot of these efforts.
Yeah,
And as I say, having worked with several of them, the most recent of which I just alluded to. So
that's amazing.
great news.
When you think about sort of where you've come from over the last couple of years, let's say I recognize how slow sometimes science takes to really open up and to really be able to come closer to answers. And we think about the theme of this year's CRA and HPA annual scientific meeting, ascending to new heights, peaks of innovation in rheumatology. So I'm going to ask you, Dr. El-Gabalawy, think back over the last year or two and what you think has been a great, move forward in science and where that might take you, particularly in your field of research, but also things you've seen outside of your area of research that you think are going to hold great promise in the near or not too far off future. It's the crystal ball peering part I warned you about.
All right. Okay. Let me give you some thoughts about
Okay.
have a little time to think about
Yeah.
that. So number one, as far as rheumatoid arthritis is concerned, as you already alluded to, our work and the big international effort to identify individuals at risk and modulate them. You alluded to our work with nutritional supplements. And I will just mention them now. I mentioned them before on your broadcast, but a combination of curcumin, vitamin D, and omega-3, we feel is very well suited to potentially reducing the risk. We have to prove it. We're not going to sit here and tell you about testimonials. We want to provide evidence, immunological and clinical ultimately, but recognizing that individuals who are at risk of developing rheumatoid arthritis based on having their autoantibodies in the blood but not having disease, we have to, our studies suggest you have to wait 5 years before,
Right.
on average, before they do that. So to power a study like that and wait, yeah, it's really difficult. So we're actively looking for biomarkers that actually tell us with these treatments, we're doing something, which is the big challenge is how do you know you're doing anything and you got to just wait and wait and wait and see what happens?
Yeah.
Things may never happen. As you well know, many people with the autoantibodies never develop disease. In fact, we've shown the autoantibodies disappear in a substantial number of people. So how do we show we're actually doing something to reduce risk? That's the big challenge that we're facing right now. So that's the RA prevention area. We've been in last year, two back-to-back papers published in the Lancet showing that a biologic, abatacept, is actually substantially modulated the onset of rheumatoid arthritis. Individuals who were very close to the disease beginning had what's called clinically suspect arthralgia, aches and pains. One study with autoantibodies, another autoantibodies were not necessary, and some of them had MRI evidence of inflammation, but were yet to have swollen joints and so on. And the abatacept did seem to make a difference, primarily delaying, but in some cases, I think there was true prevention, and the data analysis is ongoing. So those are very promising studies. Having said that, we're working with the nutritional supplements, as we suggested, at what we think is an earlier stage when the probability of developing rheumatoid arthritis is lower, but we stand a better chance of actually preventing disease because we are prior to the point that we like to think of the point of no return, where the immune system kind of crosses a bridge, becomes evolved and matured, the autoimmune response to the point where it's very difficult to turn it around.
Yeah.
So that's RA prevention. That's where we stand with that. In terms of other aspects of RA, I think there has been a huge recognition that the RA we're seeing now, even at the very start, is associated with dramatic comorbidities, cardiovascular comorbidities, respiratory, interstitial lung disease, and a variety of other comorbidities that really impact on our ability to look after people, even, as I say, people with early onset rheumatoid arthritis are coming to our offices with a lot of other problems that need to be dealt with. And the complex interaction between these different pathologies makes it a lot more difficult to balance out the pharmacology, the non-pharmacologic interventions, and so on.
So these are things, pardon my interruption, but these are things that happen, these comorbidities, after you have RA, or are they precursors to development?
A very interesting question. We know for a fact that people with RA down the road accrue more of these comorbidities than people who don't have RA, particularly the cardiovascular and the respiratory and some musculoskeletal osteoporosis and so on. But what we're finding now, and I would direct your listeners to a paper that was published in the Journal of Rheumatology, and then I was asked to write an editorial about that with Carol Hitchen. But the paper was out of Sherbrooke, Quebec, and Gilles Boir's group, and they had published a 24-year study where they looked at all of the individuals who entered into their cohort of polyarthritis being referred from primary care. And they wanted to see over the 24 years, does rheumatoid arthritis still look the same now when it presents as it did 24 years ago? And the interesting thing is that they're seeing patterns that look like the disease itself may have changed. It's more seronegative. We don't. Having said that, this is primarily a French Canadian Caucasian cohort that they looked at, but some very important observations made there about how rheumatoid arthritis is actually presenting now. They feel that the data suggests that it is presenting maybe milder, but most importantly, much more comorbidities at presentation. So the patients are presenting with early rheumatoid arthritis already with cancer, cardiovascular disease, lung disease, a whole bunch of comorbidities that perhaps they didn't see as much of 24 years ago. So that's
Yeah.
an important observation for us to keep in mind.
Yeah, I read some of those articles. Some of that is even leaked into mainstream media that talked about, RA today being milder than it was. So for our audience, Dr. El-Gabalawy, describe what that looks like. What is milder in terms of the RA itself?
Yeah. So again, I refer back to this excellent paper.
Yeah.
Milder means that the inflammatory markers aren't as elevated. Interestingly, the number of swollen joints and tender joints really didn't seem to be a whole lot different now than it was even 24 years ago. Less autoantibodies, and generally people with seronegative rheumatoid arthritis tend to have milder disease. Less erosive damage to the joints themselves when they present. So those were the kind of definitions that were used to say that's milder disease. Uh, is it easier to control with medications? They really didn't comment about that in this particular work, but individuals with seronegative RA are notoriously difficult to find treatments for. The things that all we know really work really well for the more severe seropositive disease, the TNF inhibitors, the IL-6 inhibitors, so on. A lot of times the ballgame's quite different. People who don't have autoantibodies still have swollen joints, still disabled substantially from the inflammation. So I think it's important to keep that in mind in terms of models of care.
Yeah, and when we hear as patients the word, or we read in mainstream media or even the scientific media, or journals, that it's milder, that doesn't equate to, oh, we don't have to treat you as
Right.
aggressively. So I think that's a really important point for people who are out there, and listening. You still have to pay great attention to managing the disease as quickly and as early as possible.
Yeah, yeah, and importantly, again, this even though the disease is milder, there's a lot more comorbidities. So your choice of medications is really predicated by what can you use. You can't use this because there's lung disease. You can't use this
Okay.
because so on. So the management becomes difficult. And one of the things in the editorial we advocated for is these multidisciplinary clinics that can address the hypertension, the lipids, the diabetes, all of the comorbidities that we're seeing.
Yeah.
One other really important observation made in this study is the carrière is the first author, by the way, if your audience
We
wants to look.
will we will link to it for those who
Yeah,
can find access to a journal for sure.
yeah. It was the alarming use of corticosteroids as the patients entered the rheumatology clinic. So, initiated by the primary care providers, there was an almost doubling of the number of people who are on corticosteroids.
Wow.
And that's quite alarming. We all know now that the downstream effects of corticosteroids, especially prolonged, persistent use of corticosteroids, dramatically increases cardiovascular morbidities, bone loss, all of the things and to see that the rate went from 18%, I think, to 34% of the individuals that presented to the rheumatology clinic, the tertiary care, were on steroids. And I found that quite alarming, as did the authors.
Yeah, there's a rheumatologist who's now retired. But he used to advocate that if a family physician could make a quick call after suspecting, let's say, for example, rheumatoid arthritis, that they should have the skill set and the knowledge and the confidence to prescribe methotrexate right off the bat,
Yeah.
and thus taking corticosteroids off the table as much as you can.
Yeah,
Um,
and in fact, there was not an insignificant number of people did come in exactly that scenario. The primary care provider did start methotrexate, but one of the things that we kind of reading between the lines, in individual who's seronegative, they're not quite sure what this is. In a
okay.
seropositive person, this is RA, we can start methotrexate, but maybe the increase in the seronegative polyarthritis made them maybe a little bit more unsure that this may represent something that responds to methotrexate. So we're speculating. The one thing for sure is there's a substantial increase in the use of corticosteroids.
And that is alarming for sure.
Yeah.
Um,
Okay. So other things, in the past year or two, there is, as I'm sure many of your listeners recognize, there has been a revolution in the treatment of lupus. Lupus was, the kind of lag behind rheumatoid arthritis in terms of all of the tools that we have to control it. And if this doesn't work, let's use that. With the recognition now of things like the interferon signature and the treatments that are directed towards type 1 interferons and the variety of different interventions that are being used in combination reminds me of RA 10, 15, 20 years ago. And so it's finally, we're seeing these therapeutic triumphs in lupus, which just, are truly amazing just because of the tremendous morbidity that we see with this disease,
yeah,
particularly
and again, in a disease where the high use of corticosteroids has been an issue forever.
Absolutely.
Yeah.
Absolutely. So that's welcome news.
Yeah, absolutely. And I think then, like happened 20 or 25 years ago, in rheumatoid arthritis and ankylosing spondylitis, psoriatic arthritis, now we have to fight with the payers to pay
Yes.
for these
Yes.
things. So it's more alike than we like to admit, actually, because we have the same sort of policy barriers, or we have faced them. Some of the provinces are picking them up, these newer therapies for lupus, but still a couple lag, the territories lag. And I would argue if you need it, the places that probably need these therapies the most are those in rural remote areas where
Yeah.
clinical care isn't as readily available. So
Yeah.
that's something that we're working on as a community to support lupus patients.
Yeah. And I mean, I think you would a lot of people would agree with us by saying if there was a common set of rules that everybody adhered to, this is the age of removing barriers between provinces, for I'm not going to say talk any politics here, but
Yeah.
this certainly is an example of where we could have a standardized approach to how to treat what's available under what circumstances, so people in BC don't get a different set of regulations than in Ontario, than Manitoba, and so on. I think it's, and especially with this revolution that we're seeing in previously very difficult to treat diseases like lupus.
Yeah.
Okay, other things. I think we are seeing finally the dawn of disease modifying drugs for osteoarthritis. And it's really going to be based on mechanistic understanding of what it is that's really driving the joint destruction and progression in osteoarthritis. Can we really modulate this? And I'd like to put in a plug for particularly Dr. Tom Appleton and his group at Western University, who are doing absolutely fabulous
He's
work.
one of our heroes.
Yeah,
Yeah.
yeah, yeah. Understanding the mechanisms by which things are happening in the OA joint, and then coming up with strategies that are much better targeted at the mechanisms of joint destruction than we were previously capable of.
How far off do you think they are? Because as we know, and even people who are watching know, Dr. El-Gabalawy, OA, it makes up, the huge bulk of the word arthritis. When we talk about 6 million plus Canadians living with arthritis, I don't know, 90, upwards of 90% are living with osteoarthritis. So when you say, you tell us about this exciting news, peer into that crystal ball, how far off do you think? We're not going to hold you to this.
Yeah, I think 5 years is a reasonable benchmark.
Okay.
By the time clinical trials get done, I mean, one of the problems with OA is that it moves along slowly. So getting appropriate outcome measures, is the joint really getting narrower? Obviously we want to treat pain, we want to treat the symptoms, but are you actually impacting on a structural damage? And no, it's tricky in OA. It's unlike it is in erosive diseases like RA, where you can do an X-ray a year later and you see if you made a
Right.
difference. It's a little bit more difficult, but I think that once these the barriers to the clinical trials and multi-center clinical trials are really become standardized, and particularly in a collaborative country like Canada, where we like each other, we meet at meetings like the CRA, and we talk about things and we do things together. I think that a 5-year window is a pretty realistic one
Okay.
for true disease modification in OA. And okay, so just moving right along.
Yeah.
Yeah,
You're chock-a-block full of great news. I love this. This is great.
yeah,
So does our audience.
yeah. We cannot ignore the huge impact that AI is having on our entire research enterprise, on clinical care, on every aspect of obviously our entire existence as
Right.
a civilization, but particularly in medicine. Um, and this weekend, I put in a plug for my colleague Jack Cush, who has a blog called Room Now, and they had Room Now live, and they had it this weekend, and I had the privilege of attending that virtually, and one of this there was a lot of AI content, but one of the keynote speaker there was she spoke about now her name was Charity, yeah, but she was previously a public health officer for the state of California, initially Santa Barbara County, I think, and then the whole state, and she helped shepherd the entire state of California through the COVID-19 pandemic, figuring out what needed to be done. And then she emerged from that, and as from a physician, to embracing the AI revolution, becoming the CEO of a bioterrorism company that uses AI to track patterns of change that would indicate that there is a new biological threat to the United States. She describes working now with 22-year-old people from Silicon Valley who know nothing about medicine, but she talks about how ultimately it's the mind of the physician. Uh, in a differential diagnosis, they know what's most likely, they act on that, but they got to mitigate the risk of what's unlikely but much more dangerous. It's really a great. I think Charity Dean maybe was her
Okay.
last. But look it up. She is a physician, public health person, saved the state of California, and transitioned to this new career that's very much AI based and bringing the wisdom of medicine to guide AI, as opposed to what often we see, which is here's this, use this, change your practice, and so on.
Well, we are definitely going to look that up, link it at the end of this lovely discussion. And I myself will be watching it tonight. So thank you for that recommendation. It sounds
Yeah,
fascinating.
yeah,
Yeah. So, Dr. El-Gabalawy, you've been so generous with your time. I sort of want to wrap us up and let you get on about your busy day with this sort of last question. When you think about all of this exciting, I think, innovation that you've just talked about that's happened in your own research program, but in others as well. And if you kind of turn your eyes out and you turn your voice out to the patient population, so people like me who are actually living with one of these over 100 types of arthritis, um, what would you recommend to people just in general when they hear the word arthritis from their physician, no matter what type of physician it is?
yeah, yeah.
What would you say to them?
I'd say several things. Number one, there has never been a better time to have arthritis. right? And I think that what we've just spoken about the last few minutes,
Right.
and you know, I mean, if you it's looking at the glass as half full versus the glass as half empty. I think that there is a lot to rejoice about in terms of where we're going in the identification management of these truly devastating, particularly the devastating forms of arthritis that you know, I mean, your listeners are well versed in how it can completely destroy a life very rapidly. Um, I would advocate for lifestyle changes that are now beyond kind of question. That all of the things that we've been talking about, the evidence base is accumulating. That diet makes a difference, exercise makes a difference. Excuse me, mental health makes a difference. All of the things that we need to focus on to you know, help us live with a chronic disease all matter, and none of them are easy. You know, to adopt a healthy diet, and again, there's now well-established guidelines for anti-inflammatory diets and so on. You know, and you know, these are you know, I think well known to most people now, the Mediterranean diet and so on.
Mm.
Exercise, you know, very encouraging data on exercise. The whole obesity problem has been, you know, addressed with a lot of new medications. The GLP-1 inhibitors have been a game changer. And so all of these come together to really make an impact on where we are right now. So pay attention to those things. Pay attention, particularly to mental health, because you know, it's easy to be brought down by you know, the all the negative press that we're hearing from so many different sources, when really the glass is very much half full.
That's great. I love that advice. Self-love is probably the center of everything, isn't it? Like self-care, self-love. And the glass is half full has always been the way I've described you and your attitude towards science and life and the care that you give your patients. And we couldn't be more grateful, Dr. El-Gabalawy, for all the time that you've given us in studio, at meetings. You've been such a great mentor to our team, and I know to your own patients, who are really blessed to have you as their physician. So thank you so, so much for joining us today.
Thank you, and thank you so much for being such a potent and effective advocate. And my true appreciation to you and your listeners for the difference that you've made.
Great. Thank you so much, Dr. El-Gabalawy. Very
Cheers.
generous of you to say.
You bet. Thanks.
Okay.
Bye-bye.
Cheers.
Bye-bye.